All right, I see participants stacking up. So we will get started in just a minute here. I think we're up to about 25, and I think we had 70 registered. So just give us a minute here, folks, and we'll get rolling. It looks like we've settled out on participant count. So why don't we get cracking? Appreciate everybody joining. Good afternoon or good morning, depending on where you're joining from. My name is Trey Sutton, and I'm really pleased that everybody's dialing in today or listening in today for today's conversation. It's one that we're not necessarily excited about the topic, but we're excited to collect a group of professionals that care deeply about their respective organizations, the members that they serve, and have points of views on how to deal with some of the changes that are upcoming. We want this to be interactive as much as possible. So folks that have questions or want to weigh in and add their thoughts, please just raise your hand. We'll either take you off mute, or you can just submit your comment question in the chat, and we'll get to it with the right individual weighing in on the particular topic. What we wanted to do first, though, was just start with introductions. I'll do a quick version of myself, and then in no particular order, why don't we go Dr. Parrish, Dr. Tischler, and then over to Jeremiah, and I'll get us kicked off. My name is Trey Sutton. I'm lucky enough to be one of the co-founders at SIFWell. We are an organization that works with health plans to identify what resources, point solutions, support services, or programs are most appropriate for individual members. It's a need in the market that I identified in some of my previous roles, having been the CFO of Medicaid North Carolina, and then the CEO of a managed care organization that served individuals with mental health, substance use disorder, or intellectual and developmental disability diagnoses. We were mostly a Medicaid program, and basically built the company I wanted to have in my previous roles. And so, I'll be weighing in both from a SIFWell perspective, but also from a finance perspective as a former CFO and then as a former operator of a plan. So with that, I will pass it over to Dr. Parrish for an introduction.
Good morning, good afternoon. My name is Brooke Parrish. I am an executive medical director for HCSC, focusing on government programs, and within that, New Mexico and Texas Medicaid and Medicare. Both an internist and a psychiatrist by training. Thank you so much for being here.
Dr. Tischler?
And I'm Lori Tischler. I'm a primary care doc by training, and I'm the Chief Medical Officer at Community Health Options, which is one of the two remaining co-ops that were founded under the ACA. So the majority of our membership are individuals on the exchange market. Also glad to be here today. And Jeremiah.
Hi, everyone. My name is Jeremiah Rigsby. I'm the chief of staff at a health plan called Care Oregon. We have about 500,000 people on Oregon's Medicaid program, which we call the Oregon Health Plan. We've been around for about 30 years throughout the state of Oregon. Most of our members are in the Portland metropolitan area, but 4 hours south, we have about 65,000 members. And on the north coast of the state, we have about 35,000 members. My background is in public policy. I worked for 2 members of Congress in DC through passage of the ACA, and came out here in 2011, and I've been at Care Oregon since 2014.
Great. Thank you, Jeremiah. All right, so the bulk of today's conversation, we want to get to the point in the conversation where we're really talking about practical ways, the way that the plans are thinking about potential cuts, how they're planning for it, some things that specifically are being done. And again, to the folks that are dialing in or listening in, would love to hear your thoughts as well on that particular topic. But just as a general setup, it's become clear, I think even before the election, it was clear that cuts to certain programs were on their way. In the Republican proposed budget, we've seen cuts upwards of close to $900 million for Medicaid alone. For the participants on the panel today, and maybe Dr. Parrish, we'll start with you. How are you guys bracing for what appears to be pretty significant cuts? And then why don't we just go around and would love to hear kind of the current mentality, how folks are feeling, what you're thinking about, how real are these cuts, and what are you seeing at the ground level?
Thank you. Yes. The two states, New Mexico and Texas, are very, very different in terms of what we are probably going to be looking at. One, New Mexico is a very Medicaid expanded state with over 40% of our population on Medicaid. We do have a very supportive governor. So at this time, I don't see huge cuts coming because New Mexico has been doing quite well with the oil and gas. So I don't think specifically. Texas, I think their risk is a little bit higher, if not much higher. It is also a very different population of mainly children, pregnant moms, and those that are disabled because it is not a Medicaid expanded state. So we are really looking at some of those contracts. I think some of the value based contracts can very much be helpful in this area, that we can really look at getting the quality providers along with still being able to get our members the services they need. We're certainly looking at our various value add. We also are looking a lot at the social determinants of health and how can we really identify those social determinants of health and get those members what they need so they don't need those higher levels of care, that we can keep them in the lower levels of care, the wraparound services. And so that's really, I think, our focus. And certainly for New Mexico, really the social determinants of health as well.
Awesome. Dr. Tischler, what would you add to that?
I mean, I agree with everything that Dr. Parrish said. I think that there's a lot of uncertainty in the exchange markets right now because we know that the enhanced tax credits will go away at the end of this year. So it then becomes the question about whether, you know, states will be able to continue to help people subsidize their care, or whether people will very unfortunately need to make decisions to go without care. But agree that we need to really look at the things, the upstream things, to keep people out of the hospital, out of the emergency room, and how can we support our members to get the things that they need in all kinds of different settings.
Yeah, and Dr. Tisch, you mentioned the tax credits. I mean, when we're looking at these cuts, they also, you know, I mean, we're hearing about things like utility assistance, rental assistance, the food assistance programs, you know, even cash benefit. It feels like there's a lot of different areas that that are being looked at to reach some targets for the Republicans that are now in power right now. Dr. Parrish, I mean, given your experience on the BH side of the equation, how are those precursors, those social supports, how do you begin to see as those begin to dissipate or maybe even evaporate? How does that flow through to the BH side of the equation? And then Dr. Tischler, you're on the primary care side. They begin to manifest there as well. Would love to hear your perspective about some of the supports and how that might ripple through the system.
I mean, I think it comes down to very much, you know, Maslow's hierarchy of needs. You definitely need housing, you need food, you need shelter before you can really start taking care of the other aspects of your health. And people are going to do what they need to do to get the lower levels of those shelter, food, etc. So if we do cut off those social determinants of health, that we will see much higher levels of care. I think everybody right now, be it vicarious or actual, is feeling increased stress. And I think really looking at how can we fortify folks so that their stress tolerance goes up, be it learning those tools, hopefully in those lower levels of care, so that we can sort of ride through all the different changes that are happening now and are going to continue to happen, I suspect. And some of those solutions that we look at, you know, are both technology in terms of telehealth, in terms of various solutions such as like Learn to Live, which will teach cognitive behavioral skills, things along those, which is open to every member pretty much through that has a policies through HCSC, care coordination, making sure that folks are connected where they need to be.
Yeah. Dr. Tischler, what would you add there? Yeah.
I think that one thing that I think about is that when, and I don't know that we've seen this to this extent before, but we've seen cuts to social services and cuts to various social determinants of health before. And I think we see the burden then will fall on primary care for people lucky enough to have primary care and to be able to get it, will fall on behavioral health, and it will fall on the public schools. And so I think that being really cautious about not automatically cutting out things that might be less expensive but have really tremendous value as we think as health plans about how we're gonna help people. And so one of the things that we are trying to do is, you know, really ensure that everybody has a primary care doc, and if they do, and that may mean that they're gonna have a virtual primary care doc, which isn't a bad thing or necessarily second rate, but really working with our population to make sure that they've got that entry to care, they've got somebody to reach out to, and that they don't have to automatically go to urgent care, to the emergency room, or to the hospital. I think we all know that there are patients who are sick enough that by just showing up at the hospital, they're going to get admitted, even if they might be kind of at their baseline. Yeah. So I think really thinking about what are those programs, how can we stretch the things that we're doing to make sure that we're still taking care of people. And you know what? I mean, I don't want to be completely negative. I don't feel completely negative, but there are going to be losses, and we're going to see them.
Yeah.
People are going to fall through the cracks. And people are going to have a harder time getting some of the things that they need. And ultimately that tends to make people sicker, both in the behavioral health space and in the physical health space, since, you know, the head and the soul are part of the body.
Yeah, that's helpful. And, you know, I mean, that's where a lot of our conversations have, a piece of that has been where a lot of the conversations we're having, where my SIFWell hat is, what are the supports and services that have the greatest impact on the specific members? How do I do at least as much with what I've got or more where there's opportunity to be more impactful? Jeremiah, you've sat at the nexus of a couple really important kind of like spectrums, if you will, federal, state, and then you sit right next to the CEO and get to hear the conversations that are happening across, you know, the COO, ClinOps, CFO, so on and so forth. Would love to hear your perspective from those two vantage points. What are folks talking about? What are you thinking about? What are you seeing with your policy hat and then with your operations hat?
Yeah, thanks, Trey. You know, there's the easiest thing to say is I think there's a lot of things up in the air, and very few things that we can tether down to the earth and start strategizing about. But we have enough, I think, between what's happening both at the local level, the state level, and even as recently as last night at the federal level, to kind of figure out what we want to start doing as an organization to really work in service to our mission, work in service to our communities and to our members. I think the thing we say about Care Oregon in our state, which is small, you know, we have 4.5 million people in our state, and 1.4 million of those people are on Medicaid, and then Care Oregon has 500,000 of those. We really pride ourselves on being the safety net of the safety net. And in times like this, connecting some dots, both for what that means, as you were saying, Trey, On our ops side, or what that means in the state legislature is important to focus on what's tangible. Oregon has historically a revenue generation problem in the Medicaid space. And so we're working really hard to make sure we get our tax packages through the legislature. And then we look at the federal level, we know that CMS has to approve the funding mechanisms that we come up with as a state to fund the Medicaid program, right? And so we can't plan for what CMS may or may not say, but we're going to work pretty diligently with our partners in the community, with our friends in our hospitals and different spaces to make sure state legislation passes that protects the Medicaid program. And we know that at a minimum, that stability is what we need within the state. Oregon operates under an 1115 demonstration waiver, as many states do at this point. And one of the things that we really emphasize in that waiver is around the social determinants of health. And there have been a lot of questions about, what plans are doing in the space, what return on investment they can show in this space. And there are some big questions at the federal level about whether or not Medicaid plans should be doing this work. And I think one of the benefits of the waiver is we've been doing this work for some time, and you've seen our waiver adjust with different administration. What we set up in the Obama administration, what we kept going through the first version of the Trump administration, what we improved upon in the Biden administration, and where we're at now, follow an arc that shows a steady commitment to addressing the social determinants of health, but also trying pretty innovative and new things. And we are in the middle right now of implementing a benefit that really focuses on a small population that's in need of housing services. And that is happening at the same time that in the Portland metropolitan area, hundreds of millions of dollars have been passed over the last couple of years to address homelessness and houselessness. And as these financial resources, both from the federal level, the state level, and the local level start to constrict, we already have this infrastructure set up where we've been working to figure out which parts of the system are addressing which needs within our community, because a lot of this money is going to benefit the same population. We have to lean on that infrastructure at this point, I think, now more than ever, which is uncommon. So how OPS is dealing with the Oregon Health Authority to make sure that we are processing incoming calls for our members about immediate rent assistance and looking at the resources that are in the city or county, that feels like the work at this point. And that's work that was different than a couple of years ago. And it's not predicting the future of what's coming, but it's recognizing the resources that we have and how we can use those differently in the time that we're in right now.
I really like that a lot, Jeremiah, and you're already starting to get into the practical steps folks can take. It feels like this is all coming at the most inopportune time. If you got at least on the Medicaid side, you've got a rate setting cycle where utilization was down and rates were up as a function of PHE, and that's come to an end. And now rates are being set accordingly. You've got top-down cuts happening. So there's a lot of kind of waves coalescing or coming together for a bit of a perfect storm. It sounded like some of what you were describing, Jeremiah, was around understanding how to braid funding streams together, understanding where existing infrastructure relationships have, would love to hear the group's thoughts on, in the time of easy money, not that there was ever times of easy money, but better times, I suppose. Some of those community relationships, some of those CBO relationships may have dried up or were lapsed for various reasons. How are you thinking about resurrecting those, reforging those, thinking about alternative and new funding sources to braid some of those things together, like meal delivery and housing and social connectedness and some other things? Where are you three in thinking about those relationships, forging new ones or rebuilding old ones? And how important is that to your members?
Absolutely.
Dr. Parrish, you want to go ahead? Yeah.
Oh, absolutely. Yeah, hopefully we haven't let too many of relationships go fallow, but certainly we are looking in the community resources, be it for housing, be it for food delivery, be it for any of those social determinants of health. One of the things we're doing is expanding what we call our member care fund, and our member care fund allows for things that are not traditionally provided by Medicaid, rather, that will help that members basically social determinant health. We've done everything from paying licensure fees for somebody to get their CDLs so that they're able to get off of Medicaid and actually get onto commercial, to buying camping equipment for someone that wished not to go into traditional housing so that they could have a shelter, to you know, improvements in bathrooms, things like that, so they can stay in the house that they're in, if they have a handicap or something along those lines. We have a housing coordinator that is goes out and forges those relationships within our community in New Mexico of who is working on housing and how can we partner with them. And each of those relationships look different, but it is definitely something that we work on basically forging and really strengthening at this time, because I think we really are all in the same boat. We all want the same things. And if we can start rowing together, you know, even better.
I think I listen to that and I feel sort of jealous because with the in the marketplace, it's we would love to do so many of those things. I think our members are, you know, just slightly above Medicaid, but we don't have as much, you know, of the premium dollar to do that kind of thing. But that also then makes it that much more important, I think, for my, you know, care management team to know what's out there, right? If we can't have the resources internally, which, you know, wouldn't make sense given our population, but how do we know what's out there in Maine? And, you know, Maine is, President Trump is not very happy with Maine right now, but what was I going to say? That we have the opportunity to help connect our members with the kind of services that they need. And it's, you know, doubly complicated. I think all of our states have, you know, urban, very kind of typically urban areas, but also very rural areas. And how do we make sure that the people who need access to social determinants, to rides, to maternity care, you know, who are up way at the top of Maine in Fort Kent, are able to get what they need. So for us, it's that much more important to both, you know, build, maintain, keep these relationships, and be really creative.
Yeah, I'd say, you know, Trey, I think you said something right. It wasn't a time of easy money, but there was a point over the last couple of years where, for one of the first times in my career, a lot of these tough issues that we're trying to deal with, both in the traditional medical model and in social determinants and things outside of that model, money or the amount of money wasn't a factor. That's an environment I've never really been a part of, and that's changing now, right? I think we are fortunate in the state of Oregon to have, whether it's in Jackson County and what's happening with our community-based organizations in Southern Oregon, or whether we're, you know, Portland metropolitan area, and people I think understand what Portland is. But we have a lot of really well-intentioned people rowing in the same direction for the good of the community. But when money, I think, was more abundant, we didn't have to talk to each other as much, right? Everyone kind of is like, yes, we understand what you're doing, but we're going forward. And
right.
I think, you know, right now we're seeing a little bit as this kind of wave crashes economically, and things are so different for our community-based organizations in our different regions. People really coming to the table to say, what do we need to do different? You know, Care Oregon, as an example, made a really uncommon investment in the city of Portland to set up a few pilot projects to reduce really ambulance rides to the emergency department, working with the fire department to send folks into really non-urgent calls and help really coordinate care within the community. And that has turned into something a little bit different than what we started. But what it has turned into, which, talking about operating funding, you know, there's money in the state coming to deal with substance use disorder, and we had decriminalized small possession of drugs for a bit and then recriminalized it a bit. But there's a lot of money around what was happening there, and having that money go into you know, overdose prevention, and using this program that we started with the city that's drawn other people into this table, and now trying to get the city and the county to talk about billing Medicaid. Those conversations didn't happen together when money was prevalent. But
Mhm.
now we're saying, how do we kind of take all these different pieces of funding with these parts of the community that hadn't really had to work together and talk about working at the same table? I think there's a lot of optimism in that, because that seems to transcend a lot of these changes at the federal level. It's not that we aren't impacted, and we're starting to very much see the tangible impact of some of these directives at the federal level. But I do think that everyone coming at a different pace into the same table now is us kind of working together on the local level to figure out from a system perspective what's best, for our members, because we're all serving the same population with much more limited resources.
That Jeremiah, I think that's such a good point, and it made me think of this. Is probably a little bit of a lob to you, Trey, but is being able to prove that the things that we're actually going to spend the limited dollars on are going to be good for people. And I don't mean necessarily as an ROI, but is it going to, in dollars? But that would be good too, of course. But would it, will it work? Will it improve health? Is this more than a good idea? So do we have some evidence base? Do we have some evidence base? And if we don't have evidence base, let's get it. Let's study what we're doing.
Yeah.
And then how do we pinpoint our members who are going to benefit the most from the unfortunately limited things that we're going to be able to offer them?
Yeah. And Dr. Tisha, I mean, that's exactly where, where the conversations that we're having are going is, how do we better understand exactly what intervention, support service, or program for exactly what member? What does our inventory of support services or programs, point solutions, et cetera, look like? Where do we have gaps in kind of member need relative to inventory of support or service? Where do we have existing relationships outside of our organization? Where don't we? Where do we need to build those new relationships or reforge those relationships geographically or by specific need? And then begin to match all those things up along with a kind of a campaign to get organized around recruiting those additional dollars or meal delivery, additional housing units, whatever it is. Those really are the bulk of the conversations that we're having right now. For the folks listening, would love to kind of pull back the curtain on how you all are organizing that bit of work. Where is it sitting? Is it inside your organization? Is it inside your care management team? How have you structured those work teams in that organization to date? Or is this really just beginning to start? But giving folks a semblance of how you're tackling some of that work would be, I think, really helpful. And then this is where I'd really love to invite everybody to kind of add from the audience or ask questions, because we do want to get to the practical ways to tackle some of these funding cuts. And I'll let whoever start with that one. I know there's a lot to it, but how are you organizing and executing to figure out exactly what members need what supports and services?
I think a lot of that comes through both care management and actually utilization management on our side, because it's often the folks who might hear first about a high need member. And, they are really great on our team about making sure that we refer to them, through care management. But we're also trying really hard to use predictive analytics and risk stratification to figure out what do people need, who are in that high risk group. And then we spent a wonderful couple of hours in our office yesterday talking about what can we do for the low and medium risk people so they stay low and medium risk, which is good for everybody.
Dr. Tischner, I think you made two wonderful points. One is that we need to get out what our work in social determinants of health is impacting members, and a lot of that gets kept internally as opposed to getting actually published and things like that. So thank you, you've inspired me, because we certainly have some internal of great ROI on like different housing programs and things along those lines and transitional living programs. the other thing you're saying in terms of partnering with the CM and the UM, we have some partnerships with hospitals that help
Yes.
by the SODH. But it also helps with the UM at the same time, because at that point it helps them because they're not having to, go to peer, because we already know what's going on with that member, within that partnership, and reviewing the cases and making sure that their SDOH, the members' SDOH issues are taken care of before discharge. So I think it benefits both, member, the hospital, and, in terms of looking at saving those dollars. And again, thank you for those points and reminding me.
Thank you. And I think your point about the hospitals, and really, I mean, I think health plans and provider organization, we can do better. We can do better about the way we work together, which is good for everybody. And that's something that, we're trying to push. I think, the three of us are all in organizations that I think are able to be very clearly aligned with our provider groups. So how can we support that? Support the, what is now the quintuple aim, but of getting our patients what they need, getting value, and hopefully keeping a steady, reliable physician and clinician workforce.
Yeah. I love that there's a little bit of learning happening across the panelists even. It's exactly why we do these. And that goes for the audience too. If there's opportunities for you to share your expertise, please do. I mean, Jeremiah, in some of what you shared, and by the way, for the panelists, we've got a couple questions coming in. I'm going to get to those in just a minute. Jeremiah, in what you shared just a few minutes ago, you talked about the fire departments and some other entities. I mean, it sounds like you all have got some advanced thinking and coordination already going on. Can you share how that's happening, how it's being organized, who it's under, all the rest of it, so folks can do some pattern recognition there as well?
Sure. First, I'd like to say with Dr. Parrish and Dr. Tischler's last conversation, it's really interesting to hear how different people think about something that we've oversimplified as return on investment, really talking about how it impacts utilization management, or how it impacts how we're showing value in what we're investing in. Because I think when we started in this demonstration waiver maybe 10 years ago, it was all academic about all the benefits of really investing in determinants of health, and right. And we are now realizing it's not as, we know our population is healthier. Like, we know anecdotally what's happening. We can actually see some things in data, but we have a long way to go. Our chief medical officer and I talk a lot about what we're doing to evaluate the data connected to the interventions we're making. And so it's like, it's really interesting to hear you all talk about the same things, and really how we're trying to incorporate that into the day-to-day work of the health plan. And Trey, to your question, I think that this decade we've been in the coordinated care model, a little bit more than a decade now. We were kind of tasked with this broad horizon of innovative work outside the traditional medical model. And this most recent iteration of the waiver is really getting towards kind of a medical, like making some of this social determinant of health work into a bit of a benefit. And I would oversimplify that piece where we're at now as developing a provider network to refer our members to for housing needs or food insecurity needs, or even things connected to climate change. And while the population that this new waiver is focused on is actually pretty small compared to the horizon of the Medicaid population we've been trying to serve in innovative ways, some of the promise, I think, what's happening around the waiver is this forcing of all the managed Medicaid plans, all the coordinated care organizations in the state, to build this provider network in service to a benefit that should be uniform throughout the state, as opposed to each of the different plans in the state kind of having a different interaction with social determinants of health and connecting people to different resources. And so we know it's for a really small population. We've been kind of using the waiver, I think, to focus on further developing this network of partners in the community. And it's not, I want to be transparent, it's not, rainbows and butterflies. There's been an overwhelming request for different services, because we start saying things like, hey, come to Care Oregon, contact us about your housing needs, here's what we can do. And that gets interpreted in the community a lot of different ways that we weren't expecting. So you're getting a lot of calls from our members, which is great. And but we're also trying to figure out how to make sure we can get the right information from our members, then get all that information to the right people in our community so that this network, this nascent new kind of network of CBOs that we develop have the ability to move these members through and connect them to services. That's where the work is right now, right? And so even though it's for a small population, and over the years we've been tasked with this broadly, having it really connected to our waiver in the state is really forcing us to figure out the best way to move people efficiently through a new system we've set up to address these things, which is good, but it's also a fair amount of work, right? And the impact on providers, and now that our providers meet CBOs, is something I think we've underestimated.
And I think I worked in a duals plan before I came to Community Health Options. And I think, as you can't work in an organization without feeling like there's lots to do in the organization. But the community-based organizations are doing so much with so little. And then being asked to be part of the CBOs as part of the 1115 waiver and stuff, it's a big ask, and it's going to be a bigger ask, right? If we aren't able to fund those kinds of things.
We've got some more good questions rolling in. So I'm gonna back up to the first one that we heard. How important will it be to measure SDOH programs and interventions in this landscape? Probably the subtext here is that it is important, but would love to maybe for the three of you to validate that. And Lori, in particular, you mentioned ROI. Several of you have touched on that concept. Let's not leave it to folks' imagination to define the other versions that aren't financial. Would love you to expand on how are you three thinking about the importance of measurement, and in what dimensions are you thinking about ROI improving how important these programs are?
I mean, I want to know not only, and it's always interesting when you talk to both community-based organizations, but also kind of for-profit organizations who all, are out there wanting to help us as health plans. What are we making a difference in the things that make a difference to our members? So nobody likes to be in the hospital if they can help it, right? So are these interventions helping keep people out of the hospital, out of the emergency room, fewer readmissions? I mean, those are all things that you can measure with dollars, but there's also a human cost to being in the hospital. There's a human cost to sitting in the emergency room. And so thinking about those things, both, in the kind of short and medium term, I think are really important. And thinking about, the thing that we talk about all the time, right? Right care, right time, right place. But I think it's also, there was something you said, Jeremiah, that made me think about also right people. Like, are there times when somebody needs a nurse care manager? 100% yes. But there are also times when somebody needs a care navigator or whatever, a community health worker, those kinds of things, which are relatively inexpensive from a salary point of view, but looking at, sort of what's the downstream savings if we get somebody to have enough food and enough heat that they don't go to the emergency room because they're hungry or cold or hot, in the case of Texas and New Mexico.
So I definitely agree. I think Dr. Tischler with a lot of what you're watching and kind of how we're seeing it within whether it's ED utilization. I might answer the question sort of by kind of naming what it feels like our motivators are, maybe our masters are. Like, so from a public policy perspective, we're talking about how much money you're saving the healthcare system. From a human perspective, we're talking about the impact on people's lives, right? And whether or not they're healthy, regardless of the dollars we're saving the healthcare system. And I think that we also are trying to figure out you can say equity, and equity has become a huge term, which populations we focus on the most. So we're focusing on populations that have been historically marginalized from the healthcare system. Does that mean we're investing in traditional health workers and community health workers? to bring folks in. We are lucky in Oregon to have the Healthier Oregon program, which provides basically the Medicaid benefit regardless of immigration status. And we pay for that out of our own pocket as a state. What is our obligation to that population in these times?
Mhm.
And what should we be focusing on to make sure that they feel as though they can receive the care that they are entitled to in the state of Oregon? And do we measure success in ED department utilization decreases? Do we measure success in what this looks like from a budgetary perspective?
Mhm.
Right. I think it's all of those things. But for now, it feels like we're not being. I think we all want to justify that this is happening for a more efficient healthcare system that is really being good stewards of taxpayer dollars. I also think that and I'm going to say this kind of switching gears from social determinants of health in the behavioral health space, the legislature has put almost $1 billion into the workforce system. Here, Oregon has put hundreds of $millions in the workforce system, and we've seen a tremendous impact.
Mhm.
Utilization has gone up 30%, and that's what we wanted. We had behavioral health. There's also a cost associated with that. And the conversation I think we need to start having as a state is really around not just return on investment. I think some policymakers are saying, well, if we're seeing utilization in these services, are we seeing a decrease in services over here in this part of the healthcare system? And sometimes we're like, if it's a community that hasn't been using these resources and they're now using the resources, that's what's happening. It's not because it's saving money over
Right.
Right. Or if we've underinvested in a part of our healthcare system, like the behavioral health space, and now we're making services available regardless of which community the member's coming from. This is what we were asking for. Whether or not we save money upstream or downstream or in this part of the system is maybe something we will get to. But I think right now it's kind of having policymakers wrap their heads around the fact that the point here was access to services. And if you make services available, they will be used, and that's working. So how do we budget for that appropriately? Versus saying we can only budget for it because we can show that it saved the healthcare system X amount.
Exactly. I mean, we added over the last couple of years, I think we've added hundreds of behavioral health providers, and we have a lot of utilization. We have a lot of people going to therapy, and I couldn't be happier about that. And the cost it's expensive, but you know what? If you are depressed and you have diabetes, you're not going to do as well with your diabetes. Right. And then that's going to be really expensive. And I'm, so far from being a medical economist, but it's really hard to tease that out. But looking at those services and, also I think pharmacy, we have our, medication adherence and figuring out what does it take to get you to take your medicine, and how can we get your medicine, whether it's a, inexpensive generic medicine or if it's a super expensive, what I like to call IB or AB medicine, that we're getting it to you, that you need it, that you're getting it in the right place, and that it's making a difference.
I mean, you guys make such wonderful points. I 100% agree. I mean, if you spend money in behavioral health, especially at the lower levels of care, you are going to see it in savings, not immediately, but long-term, taking the long view. You're going to see it show up in overall spend for physical health, and also looking at the higher levels of behavioral health because they're spending it at the lower levels. And again, that medication, adherence, the antidepressant does no good in the bottles.
In the bottle.
There is no magical power of it that seeps from the medicine cabinet into you. But also really working to that, the lower levels of care. And certainly I think, again, you have to really take that long view. It's not going to show up immediately. It's going to show up over a year to 5 years from those dollars invested.
Yeah. And that's really challenging in the Medicaid population and in the exchange population, because there's churn in these populations, right? People were part of the gig economy and now they got a job, so they're getting a different health plan through their work, or people got a job and so they no longer are on Medicaid. And I wish that we could look at those, 5 years is a long time in the world of economics. So I wish there were a way to kind of look at it and more holistically.
Yeah. Yeah, I mean, I think what I'm hearing is, number one, it's super important to measure it, and two, measure across the number of different dimensions, not only just medical ROI, but employment rates and a bunch of other things, and particularly in the ways that speak to folks making decisions about where funding's going to go. I got one, oh, Dr. Dishley.
No, I was just thinking, and finding the right language to
Yeah.
explain it, which is, I think,
Yeah.
going to be a challenge for those of us who kind of believe this in our hearts, right? So how do we find the language to explain the things that we're saying that speaks to the current federal government and some of our state governments?
Yeah. I saw you smile, Jeremiah. Having worked with legislators, I'm sure that one was resonant, figuring out their language.
Yeah.
All right, we've got one about, it's this whole notion there's always somebody bigger, and these things tend to roll downhill. So question about CBOs. How are they going to be impacted? How can we be supporting them? How will funding cuts specifically impact our CBO partners? Any thoughts there from this group?
I'd say that's actually been really tough, because in the part of this conversation where I talked about a lot of things up in the air, it's easy to look at Care Oregon and look at maybe a budget resolution and know that Congress is going to go investigate $880 billion in cuts to Medicaid, and know how people have talked about that over the last couple of years. It's hard when a behavioral health provider calls or a houser calls and says, actually, I think this directive is going to have an impact on money that's coming right now. We're needing to attest something or change grant applications. And that's been hard for us because we don't have as much experience in that type of direct negotiation with the federal government. And I think those directives and the impact of those directives are increasing. So what we've been trying to do, I was fortunate to, I think, get appointed to a federal oversight task force that's been being run by Oregon's Attorney General Dan Rayfield, and trying to surface some of the things that we're hearing in the community from our organizations in that space. I think there's a lot of attorneys general that are filing lawsuits and injunctions throughout the nation for a lot of the executive orders we're seeing. And I think right now we're just trying to surface the impacts, having not from an anecdotal or even from a human narrative, but just trying to make sure we're issue spotting what people are starting to see on the ground and surfacing what that looks like. Because the point is, we don't necessarily know what to do about all of it quite yet. It's taking on such a variety of forms. So that's a long way of saying it's kind of unclear,
Yeah. Thanks for that, Jeremiah. And there's another question about social determinants of health programs. Specifically, it's another North Carolinian, so shout out there. And it's about the 1115, the Healthy Opportunities Pilot, and this was a program designed to support a lot of the things that we've been talking about food and transportation, housing, protection from interpersonal violence, some other things. Just a fantastic program. The question's generally about other kind of mainline services, maybe crowding out some of that funding, how we advocate for some of that funding, how to utilize data, other methodologies to advocate. So I think we're getting into that ROI conversation a little bit. Jeremiah, maybe we circle back to this whole advocacy question, and you've been on the front line. So let's maybe start with you. Laura, you mentioned the language that we need to be using with the right folks. And so let's maybe give some folks a general construct for engaging people that are making decisions, advocating for particular programs, the notion of ROI laced into those conversations. And then there was a bit of this that was specifically about, well, we've got limited experience, and how do we communicate the effectiveness, the power of these programs when we've got limited experience? Any thoughts on all of that?
Yeah, I might say, I might say it really, we should be tailoring our messages in nuanced ways to the people we're talking to. And I say that just because of how much oxygen is being consumed at the federal level and in national headlines, from things that we all know about, right? And so in my opinion, advocacy that's important from us on the ground is sorting through a lot of those headlines to talk about what's specifically impacting people in this legislator's district or in this congressional member's district, right? And so in Oregon, we have a behavioral health issue where we're having legislators really wrap their head around success in increasing capacity. That has nothing to do with what's happening at the federal level, right? But inevitably, we're going to have a funding conversation, and that funding conversation is going to take into account what's happening at the federal level and what they will or won't approve. And I think my job is to help talk about, like, using an airport analogy, there's a bunch of planes that need to come in for a landing. And in our opinion, these 2 planes need to land first. And then we need to send that one around the airport and have that one land a little bit later. And here's why. And that's a very specific conversation for the Oregon State Legislature. But if I'm talking to our congressional delegation at the federal level, many of them already have the talking points that we need as far as what we need to do to protect Medicaid. And those that don't, we kind of reinforce just what's happening in their district in the Medicaid space, and like how many people are going to be impacted by this and what that's going to look like. And so it feels like, that's a long way of saying, again, it feels like there's a lot happening that's taking up a lot of the oxygen. Advocacy for us is really tailoring it to what what is going to resonate at a base level with the person that we're talking to, which I guess sounds really obvious, but to me it seems more important now because of how loud everything else is.
I
Somebody.
100% agree. Keep it local.
Yeah, keep it. Yeah, yeah. Look, Laura, you mentioned language. Anything else to add there, or did Jeremiah well cover it?
No, I think Jeremiah,
Okay.
nailed it.
Okay, good. All right. I'm gonna go back over to our questions. So there's one, there's one about exploring community resources that are already working well in your community. I think all of us have spoken a little bit about making those connections. There is a part of this question that I do want to pull forward though. And then for the person that asked this, if we don't fully answer, please circle back in your question. But the part I'm interested in getting the 3 of you's point of view on is, have you asked members, what are the resources that they're using? How do they feel about them? How effective are they? And so I'm sure the answer to that question is yes, but we'd love to hear more about how you're engaging your members directly on the things that they value the most, because there's a whole different vector of evaluation, which is, quality of life or some other dimension that's direct from members. So how are you thinking about that dimension?
I'm not sure we have asked, and it's a really good question.
I love it. Honesty. Yeah.
Again, I'm sort of like, we don't have a standardized, you gave me a good idea. We don't really have a standardized form. Our care coordinators are asking, because I hear about it in rounds, that they're using XYZ community resources, things like this. And this has been helpful. This still is a gap, whatever. But again, we don't have a systemized way
Yeah.
that we've currently been asking and keeping. We certainly have a few resources and exactly sort of our go-to books, shall we say. And that is sort of done and kept up with the different community resources, but you gave me an idea. Thank you.
Of course. Yeah.
I think from our side, we have a pretty interesting structure set up in statute, but I could talk about the limit to that. We have these things called community advisory councils where they're supposed to be made up of majority of consumers. We put together community health improvement plans, community health need assessments, and a lot of the community investment that we're supposed to make is supposed to align with that. And I think academically it's very good. And I think there's been a lot of good work that happens in our community advisory councils. I also think that what we're finding out after 10 years of doing that is how much we're missing still. Right. And so I talked about this waiver that we set up for housing services, and a third of the calls we're getting are things from our members that our members need that we really haven't built into this benefit. Most importantly, I think immediate eviction prevention, right? Like someone is like, I'm getting evicted tomorrow. It's about a third of our calls right now. So we have these structures set up in statute to really listen to what's happening in the community and listen to our members. We set up this whole benefit to support our members in an uncommon way. And we find out that a third of the need is something we haven't really been able to accommodate it. Now, from a public policy perspective, you know, that's a really hard thing to address in the healthcare system. I don't want to like minimize it. It's a hard thing to plan for, but you know, I think it mostly represents that this work is hard, like actually listening to what your members need and then pulling a trend out of there that is actionable happened to us by accident, not because we spent 10 years, you know, in our communities with these really strong systems set up to get community input. It happened because of what we were missing in what we set up. So
Yeah.
to me, that's been interesting for us.
And it's no small amount of work. I'm sorry to interrupt you. Go ahead, Brooke.
I
No,
was just
you
gonna
can.
say, we actually do have community listening sessions and things along those lines, but it isn't, again, for the member would have to be active to go to that listening session, or
Right.
we're the listeners, and voice it. And I'm not sure we're getting some of the folks that may be a little quieter.
Mhm.
It would be very coordinator dependent at that point.
Yeah. I mean, I would quickly say, I think one of the things that our model is built on that I don't think is entirely true is that each member is going to be incredibly active in the coordination of their own healthcare plan. Like, and it turns out, you know, a lot of members maybe don't want to spend an hour with us every month to talk about their healthcare plan.
Yeah.
Yeah, maybe that was an assumption that was a little bit wrong. And so, yeah, it's very interesting.
Yeah, I don't think any of us want to spend an hour a month talking to our health plan.
Right.
The goal is to not talk to our health plan as frequently as possible. So I will highlight, in fact, I saw one of our current clients on the call, so I'm not going to name anybody unless they want me to. But we do have a current client that's doing needs assessments and some other employing some other mechanisms in getting coverage for whatever percentage of their plan that they're getting feedback, which includes a lot of the things that we're talking about. Are you struggling with paying your utilities? Are you worried about transportation, personal safety, a number of other things? And what that's allowed us to do for that particular plan partner is do some lookalike modeling. And so by identifying a member self-identified kind of needs, we can identify others, and we're triangulating with zip code information, a bunch of other information to say, all right, well, we haven't heard from everybody, but we can begin to better understand the likely things that are impacting this member and getting the right care and everything else. And that's been a really effective way for us to pinpoint exactly what members are needing what things. And so hopefully that's a useful anecdote for everybody. And if my client wants to self-identify, I will let them, because I'd love to brag on them. All right, let me go to the next one. Geez, where are we? I always need help. All right, there's this one I had read, and I don't have a good answer, but would love to get others' reaction to. So do we see an opportunity to keep focused on social needs, upstream issues under the new administration, like Make America Healthy Again commission, to fully address the growing health crisis in America? I think that one of the fundamental points in all of this part of the question is we got to ensure that the healthcare system is promoting health rather than just managing disease. And so it's this notion of getting upstream, kind of the holy grail of the work that all of us do and have done. Any reflections on how what's happening on the funding side is going to affect our ability to get further and further upstream? Does it force us into a more reactionary disease management kind of place, or are you all feeling good about that continued mission around health and not managing disease?
As one of the states that is currently in a measles outbreak, I have concern over some of the vaccination issues, and hope that will be that my concerns turn out to be a non-issue. I am very hopeful in the Make America Healthy Again via better nutrition, exercise, preventive measures. And I hold that open as hopeful, and that some of our social determinant of health programs can be sort of funded under that. But time will tell, won't it?
I think that that's again like the language, right? I mean, if we can kind of, I don't know if sell is the right word, but that's what I'm going to use, our programs as part of Make America Healthy Again, then you know, I agree with Dr. Parrish that it might not, you know, it might not be a bad thing. But, and the other thing I was going to say, and this kind of goes back a couple of questions, it's not a simple thing to figure out what all these resources are. We just did a big update for our care management group and sort of what are the resources in the different counties in Maine and how do we access them? And it was, you know, not a small amount of effort. And in bigger states and rural states, I'm, you know, this is complicated.
Yeah. You know, it looks like we've had some folks drop off the hour mark, and that may be a lesson for us here at SIFWell. Before we lose any more folks, though, I always like to end conversations like this with really practical things that a person can take back and do either today or this week. Let's do that, and if we want to keep going with questions, we can. But I would love for folks that are on today's call to get at least a sense from you all, one thing that they can do today or this week that will positively impact kind of the environment around us. And whoever wants to start.
Sorry, I just reiterate on the advocacy thing. I think it's really being a resource for the people that are trying to sort through this on behalf of their communities is important, whether that's CBOs or electeds. And just a little bit that you bring to the table with your experience based on the work that you're doing, I think is helpful. So doesn't mean you have to go huge campaigns or anything, but just being a resource with what you're seeing, I think in these times is good.
And sometimes it's just as simple as asking a question, or I mean, I have, well, I've been in Maine, had the, you know, good fortune to work with a number of our legislators, and who are, you know, I would say almost all incredibly well-meaning. They're not clinicians. They're not, you know, they don't know. They know they want to have a bill that says X, Y, and Z, but they are often, you know, really open to, okay, these are the questions. This is how we would look at it. If something is FDA approved, is that enough, or should there be, you know, something else? And I've been really struck by, and it feels to me like a relatively small amount of work, but just to be able to get in there and talk with your legislators or talk with the, you know, lobbyists who work with your company and help them bring a bill either to fruition or change a bill, things like that. So, and I have heard over the years, you know, friends who have been in public service, and I'm sure, Jeremiah, you would say the same, they don't see a lot of healthcare workers in their offices, right? We generally are really busy taking care of patients and doing our thing. But what healthcare workers have to say, and not just from health plans, but from provider organizations, payer provider organizations, it's really powerful.
Yes, completely agree.
I would say concretely to get to know your community partners and identify exactly how you can help each other. And you almost touched on it, Dr. Tishner, take care of yourself so you can take care of others.
Yes. Put on your oxygen mask first.
That's right. Yeah, that's good. That's good. I will take a little bit of latitude on the time horizon. I would, you know, and I'm putting my old CEO hat on, figure out what your members need, figure out what you got to bring to bear, figure out where the gaps are, and figure out how to close them, and then connect all those pieces together. So I know that's not a today or this week thing, but those are various pieces of the conversation that we've covered. So I want to thank our panelists, a group of experts that care deeply about their members, the work that they do, their plans, their communities. I really appreciate the three of you bringing your expertise and thoughts forward, particularly in a way that hopefully folks can take something away. Hopefully there was something for you all throughout this discussion. And again, thank you very much. We didn't get to all the questions. If you want to ping me directly, it's trey@sifwell.ai. I'll do my best to answer the questions I can. But I know we're losing folks. I want to wrap and be respectful of people's time. So again, thank you, panelists. Thanks for everybody for tuning in today. We'll do another one.
Thank you, guys.
Thank you all.
Bye-bye.